Welcome back everyone. I hope you've had an amazing week. This is GP Made Easy and I'm Dr. Daniel Follows. So today we're going to be covering endometriosis as it is a common condition, but due to lack of understanding it has led to a delay in diagnosis and management in some patients. By the end of this video, I hope that you will be able to understand it better and be able to apply this knowledge to your clinical practice. Before we begin, don't forget to like, comment and subscribe so I know that you're enjoying this content and I'll make more videos for you all. And now on with the video. First of all, some background information. So endometriosis is defined as the presence of endometrial-like tissue outside the uterine cavity. So up here I've got a diagram, and the endometrium is the lining of the womb, so it's what sheds every month and causes periods. So endometriosis is the presence of that tissue outside of the uterine cavity. As you can see on the diagram, there's a couple there where it's formed on the fallopian tube and on the ovary, which the lay term for that used to be chocolate cysts. The condition is most commonly associated with pelvic pain and infertility, and the exact cause of why it happens is unknown, and it's estimated that it affects around 6 to 10% of women of reproductive age. It's a hormone related disease, so that's why it primarily presents in women from puberty to menopausal age. The majority of the disease is found in the peritoneal cavity, but it can spread even further, for example the bladder, the bowel, even the lungs and even the diaphragm. And the lesions respond to hormones the same as the endometrium, so hence why symptoms initially have a cyclical type pattern. And again, why I'm covering this topic, as it's been shown that due to the lack of understanding about this topic, there's an average time of about 7.5 years from presentation of symptoms to getting a diagnosis. Now on to presentation. In some patients they can actually be asymptomatic and it's just caught incidentally when they're having a scan for another reason. And in other patients they may present with dysmenorrhea, which is painful periods, and the pain tends to start a few days before their period actually comes and then during the period, compared to idiopathic dysmenorrhea where that tends to just come on during the period. Patients with endometriosis may also get pain during ovulation, and if the condition has been long-standing, the pain can then even develop into chronic pelvic pain. They may also get rectal pain during defecation, which is called dyschezia. They may get deep pain during intercourse, which is called deep dyspareunia. Some may present with fatigue. Some can present with cyclical dysuria and hematuria, and some may present with cyclical pain elsewhere. For example, they can present with cyclical pain at a C-section scar. Now, on the Endometriosis UK website, they have a symptom diary that you can give to patients to help them track their symptoms to see if it could be caused by endometriosis, and I'll link it in the description below. Then next you move on to examination. It is recommended to do a pelvic and speculum examination if it is indicated. This is not indicated if the patient has never had intercourse. Some things you may find on examination is, you may find a mass, might be tender, you might feel a bulky uterus, or you may see some blue/black lesions. Moving on to investigations. So first of all, you want to get their blood pressure and BMI, as this will help later on for management for what they're suitable for. And next you would request a pelvic ultrasound scan. Now, while awaiting investigation results, you can start them on treatment if needed. And just as a warning, sometimes the ultrasound can be normal, but that doesn't exclude endometriosis, so please make sure you reiterate that to the patient to reassure them. It is not recommended to do a CA125 unless you have suspicions of ovarian cancer and want to rule that out. Moving on to management, First of all, you want to ask what the patient's priorities are in terms of which symptom is concerning her the most, and also ask her about her plans for fertility in the future, as that will obviously affect your guidance. For pain, you can start off with simple pain relief like paracetamol, ibuprofen, or if they're not responding to them, you can up it to some neuromodulators such as amitriptyline, pregabalin, gabapentin, and next you would move on to the hormonal methods such as the combined oral contraceptive pill, the mini pill, patches, implant, Mirena coil, and we will cover these in more detail in a future video. If they don't respond to any of these treatments, or they have deep disease such as dyschezia or deep dyspareunia, then you would refer them to see a specialist. Now, some of the treatments they would give in secondary care are GnRH analogues, which essentially is a medical way of inducing menopause, or if they failed that, then they would move on to offer them a hysterectomy. But they would only move on to this if they have ongoing pain despite other treatments and they have finished their family. But even if they have a hysterectomy, we have to inform patients there is still a chance that may not fully cure the disease. That's it for today's video. I hope you've enjoyed it and learned something new. Don't forget to like, comment and subscribe so I know that you're enjoying this content and I'll make more videos. And if there are any particular topics you would like me to cover, then please comment down below and I will pick them up in future videos. Also, don't forget to have a look at the description down below where I've linked all my resources from RCGP Learning for this topic to the Endometriosis UK resources and much more. I'm also on Instagram, so if you want to view me on there, it's up here. It's the same name, GP Made Easy. Or if you want to contact me a different way, I also have email, which is up here. Well, that's the end of the video. I hope you have an amazing week and I will see you in the next video.